Good evening, everyone. I'm Akeem. I'm a fourth-year resident here at USF, like Dr. Scully mentioned. Thank you for allowing me to present this evening. I'll be presenting a case of a infected aortic stent graft. Highlights really management of a complex traumatic injury, timing of repair, and then kind of optimal repair strategies and having a multidisciplinary approach to patient treatment. This patient is a 35-year-old gentleman, history of a MVC in May of 2025, presented as a trauma activation to an outside hospital, and at that time had multiple intra-abdominal injuries as well as a dissection of his distal aorta. He underwent aortic repair on post-trauma day one. Basically took a C-tag graft into the distal aorta with kissing iliac stents. Uh, Subsequently, throughout that hospital course, he underwent multiple XLAPs and bowel resections. Ultimately, he ended up with a colostomy. Um, Around a month after his index aortic repair, he did have to return to the OR for concern of endo leak. His graft was subsequently relined on the right limb. His hospital course was very protracted. Unfortunately, he subsequently had a lot of complications regarding anastomotic leaks and enterotomies and management of a Moral-Lavalley lesion, which required multiple trips to the operating room. Uh, about a month and a half after his initial trauma, he was noted to have developed this intra-abdominal and left flank abscesses, which were at that point managed by percutaneous drainage with the IR team. He continued to have persistent drainage from his purulent drainage, and there was ongoing concern for a infected peri-aortic hematoma, which was a bud in his aorta. So he was at that juncture subsequently transferred to our facility in June for further management, with the question being, one, is this stent graft infected? And if so, what is the next step in management? So this is his presenting scan. I'll let this roll here, but uh, as the scan comes down, you'll see his aortic repair that was done at the outside facility is patent. However, there is a RP collection on the left side with some gas that's tracking up towards the area of his stent graft. His external iliac on that left side was notably occluded. You can see he still at this juncture has multiple abdominal drains related to his initial trauma. Um, so the question at this juncture was kind of a dilemma. It's like, well, here is this patient presented with this image and finding, he's had this ongoing intra-abdominal sepsis, drains, multiple operations within the last month. Is this gas up against the aortic stent graft related to his prior interventions, or is this truly a sign that the stent graft was in fact infected? So the kind of decision point at this juncture was, do we treat this conservatively, or do we offer immediate surgical intervention with explantation of that graft? Now, we opted to proceed with conservative treatment at this particular juncture. There were a few reasons for this particular patient why this is what we selected. For one, he had no systemic signs of illness. All his blood cultures at this point were negative. He had already had a percutaneous drain in this collection and was on IV antibiotics. So we opted to follow him clinically with close interval imaging for then optimal timing of his repair, one, but also to give him time to recover from his traumatic injuries. At this point, he was a month and a half going back into his abdomen, hostile tissue planes, all that RP inflammation. So we figured if we could get him through this, give him more time to recover, and then stage a repair at a later date, that would probably be his best option. We saw him subsequently in clinic in September. At that point, he was actually making leaps and bounds in his nutritional and functional status, was able to gain some weight, was working out. His RP collection had actually improved on imaging at this point, and he had been transitioned to PO antibiotics per the ID colleagues. Given the complexity of his case, he was presented at our multidisciplinary aortic conference in October. And at that juncture, we came to the conclusion that we should continue to try to manage this conservatively, giving him additional time for recovery, given that he had shown some improvement. The overall strategy at that point was we wanted first to have his ostomy reversed. We wanted to continue to optimize his nutritional status, and then ultimately repeat a scan in a few months to then plan for likely a retroperitoneal approach with a aorto by iliac graft and a possible jump to that left side if necessary, like you had seen the iliac was occluded on the index scan. So he was seen by the colorectal surgeons in April of this year for evaluation of his ostomy reversal. Unfortunately, while he had been doing well clinically, he had a small region of his flank where his flank drain had been that continued to drain scan purulence. And when they repeated when they got his scan for ostomy reversal, he was noted to have new interval occlusion of his left iliac limb, and now there was actually gas within the stent graft. So I'll let this scan here play through. As we come down, you can also see that there is more inflammation and fat stranding around the aorta itself, and left limb now occluded and gas within the stent itself. So at this juncture, we had decided, well, this is clearly now progressing to a clear-cut infected stent that could no longer wait for an ostomy reversal or further optimization. So we decided to bring this gentleman in for operative repair. At presentation, when we brought him back, he was actually having symptoms of claudication on that left leg as well, since the interval occlusion of that left limb. So the plan for this gentleman was explant of his endograft and reconstruction with autologous vein. We chose to use vein primarily given the fact that this was a infected field. He was a young patient. This would give him the best shot of long-term patency and a durable outcome for this operation. We utilized concurrent teams given the complexity of the case. We actually were joined by our emergency general surgery colleagues who performed extensive lysis of adhesions, total time around 2 hours. The duodenum notably was very adhered to the aorta, which required a fair bit of dissection. Despite the inflammatory changes, it was important to note that there was no identified fistula between the aorta or duodenum that was noted intra-op. While they did the abdominal exposure and mobilization, we harvested femoral veins on both sides for vascular reconstruction. We performed a right aorta to common iliac interposition with reversed femoral vein. And then we brought down a tongue of omentum to then cover the reconstruction to further prevent or to guard against any recurrent infection. We subsequently did a right to left femoral bypass with spliced femoral vein to revascularize his left side, given that he was complaining of claudication on that leg. For the complex procedure that he actually had a pretty smooth postoperative course. He was downgraded from the ICU on postoperative day 2 and ultimately discharged on postoperative day 7 with a 6-week course of tailored antibiotics to his cultures that grew basically multi-speciate bugs from the operating room. He was seen in follow-up. This is his 1 month post-operative scan. See here, patent repair. His aortic inflammation looks significantly improved. As we come down to the femoral, you can see a cross-femoral bypass there, which is widely patent. So in summary, this is a uncommon but potentially devastating problem to have. Patient selection and timing of intervention, especially in this patient, I believe were critical. In a clinically stable patient like this gentleman was, ideally you'd like to delay reconstruction, since that may allow you to optimize, their nutrition and recovery and their operative conditions. Once you get to having to explant this, complete explantation with autologous conduit is the preferred choice. It remains very durable. And then this kind of scenario, having a multidisciplinary approach helps to optimize patient outcomes. That is all I have. I will take any questions.
Outstanding case, and really just a sort of testament to sort of the clinical decision making that has to go in, right? Your center is well known throughout the U.S. and probably globally for managing complex infections of all kind, vascular infections of all kind, and the NACE procedure. When Pat Claggett first described that in the early '90s, I think people were sort of wondering where does that fit in the management algorithm. You obviously appropriately chose a patient who, one, could take the joke, right? It's a younger, fitter patient. And then you delayed things appropriately, I think, to try to optimize, knowing that inevitably you were going to have to extirpate that graft. Can you speak briefly to the, post-op, once you've decided to do a NACE now and you've extirpated all of that prosthetic material? Do you just do antibiotics? Does it stop after 6 weeks? Is there any oral suppression that still occurs? And the imaging, do you just image once, or they still get surveillance? How do you manage that NACE patient?
So the practice here at this institution is once the graft has been explanted, there is a 6-week course of antibiotics, and the majority of patients do go on long-term suppressants. Infectious disease in recent times have been moving away from that. In my experience, I've had some pushback, but I'd say the practice pattern here is that once you've had this explanted, you stay on immunosuppressed or antibiotic therapy long term. And then you get a 1 month post-operative scan. If your repair looks good, usually another scan at 3 to 6 months. And then usually at that juncture, people are usually surveilled, usually with just ultrasound, just to make sure there's no aneurysmal or anastomotic degeneration at your aortic anastomosis or in your femoral in this case.
Okay. I know we're coming right up on the 8 o'clock hour, and if we don't have, let's see if I'm missing anything. I'm bringing up the QA now to see if anybody else has any final questions or remarks for what was really 4 great cases. And I'm not immediately seeing one. My apologies. I'm bringing up the QA in real time. Usually my wingman, I think Dr. Anatakis, unfortunately, he lost power and lost his connection to the thing. So I'm going to, in the interest of giving back everybody the remainder of their evening, I'm going to actually call it. If there are burning questions, please feel free to send them to me and I'll try to get them to the presenters. I want to thank you, the 4 presenters this evening, for 4 outstanding cases. And thank you for everybody who attended. This is our second sort of Florida Vascular webinar. We do have future aspirations that inevitably this will be a recurring event that will actually, hopefully, eventually aspirational goals here have CME linked to it so that all providers will be even more invested in presenting. So again, please share these links and or this webinar series with friends. Use your social media handles. Get the word out, because we think this is a great way to showcase all the great surgery and the great community of vascular surgery that we have in the state of Florida. So again, thank you to our 4 presenters, and thank you to everyone else this evening. And again, the webinar is recorded and it will be hosted on the FVS website. So feel free to go back and to check out these outstanding cases. So again, Applause to you guys and thank you all. I hope you have a wonderful summer.